Oh, very good. I can see Campbell. Tiley has just jumped on. Thanks for joining us, Campbell. Welcome to the GP Collab panel. Can you hear us okay?
Yeah, I can hear you. Have I got my microphone on?
Yeah, there you are.
There you
Yeah.
go. Technical genius like everyone else. Yeah.
Did you want us to go around the group? We'll just quickly introduce ourselves. You might not know all the GPs on tonight. Does that suit you?
Yeah, sure. That'd be great. Thank you.
I'll just buzz down the list. Amita, you're first on the list.
Mic
Okay.
off. Yeah.
Microphone. Sorry. Hi, I'm GP up at the northern end of the Central Coast at Gwendolyn.
Right. No, nice to meet you.
Thanks, Amita. Con, you're next there.
Hey Campbell, I'm Con. I'm a GP down in the entrance.
Okay, great.
And Taya? He's got 3 seconds to respond.
Oh, sorry. Hi, I'm a GP at Point Clare. How you going?
Fine. Is that? Yeah. Well, I'm a hematologist, obviously, or maybe not, and based at the hospital, and am the director of cancer services there. So happy to talk about anything you want me to talk about. But I guess our cancer MDTs was the topic of the evening, I think.
Yeah, thanks, Campbell. Yeah, we do have a few more GPs, just the Georgia Page and Nat Cordawina, and myself, I'm Ellie Warren, who you know we're all based at Your Family Doctors in Erina as GPs, and we've got a representative from Health Pathways here, Erica Drew from the PHN, and some other people who you know from LHD, I believe, Fiona Wilkinson and Maya Smitron. So that's everyone on tonight. Thank you so much for joining us. It should be good. We've been talking to Elizabeth Rennicke a little bit about getting GPs involved in MDTs, and we keep getting stuck with a few sort of logistical hurdles. So it'd be nice to hear from you what you think from your end, I guess, and how to progress things.
I mean, I think I would want to start by being really clear what MDTs you're talking about, so that I talk about the same type of MDT. And I mean, as I see it, within our service, there are two, completely different multidisciplinary team meetings, referred to often, with the same acronym. And I guess I'd really like to be sure which one we're talking about. I guess the sort of cancer treatment planning MDTs that we have are one of those, which are, in our context anyway, very much focused on new cancers and treatment decisions, with mainly medical/surgically focused, although many of the MDTs, depending on when they're held, will have quite a bit of nursing, and we have a pharmacist along as well, and obviously RadOnc and MedOnc dominate most of them. And obviously there's the completely different type of MDT, which, are ward-based and relating to often, changes in treatment planning for patients and that sort of thing, which are often much more nursing and allied health focused. So I had the impression it was the former that we were talking about, but I guess I need to check.
It's definitely worth double checking, because I think I'm not sure that some of us as the GPs know the specific differences between both, and I think our discussions previously have centred on the ward-based MDTs. So we are super keen to get involved in your oncology MDTs, if there's at all a way to do that. But Fiona, did you have anything from your end to just expand on for Campbell, to make sure we've covered off everything we need to from things that we've already discussed on the panel with Elizabeth?
Probably not, Ellie. It was I think the discussion is focused around how GPs can be involved in the care of their patients, and Elizabeth put forward some options, and I know, Campbell, it's very challenging with timing and the fact that often there's discussions on multiple patients in a meeting, and so that those logistic challenges are a real complexity. So the discussion's really focused on opportunities, and is there an opportunity that it would work to actually engage with a GP?
I mean, I think it depends. Probably some background which won't surprise you, and they're issues that are going to be very common to your part of the world as well. Organisation and sort of any kind of clerical kind of support for our MDTs, administrative and clerical support, is almost non-existent. There's one part-time person supporting all of the cancer MDTs. That's not necessarily a limitation. We don't have a dedicated kind of management software package. So, and I must admit, the way I think some of the MDTs are documented and run is probably not, sort of documented and organised is probably not quite as well as I would like. But on the other hand, they're run in a way which works well for the chair and the people that attend the MDT, and the fact that those MDTs occur and discussions occur about, collegiate discussions occur about patient treatment is important, and it's more important to have the meeting perhaps conducted in a way that is less flexible from the point of view of getting the GP involved than not to have the meeting at all. So I guess, again, I'll show my inherent bias by talking about the Hematology MDT, because as it happens, it probably offers more potential than any of the others at the moment. And the reason for that, I guess we use our oncology information system to sort of organise and run our MDT, which is not the most flexible of systems, but I guess it does allow us to at least generate a patient list. It doesn't necessarily have times against the patients, which is a potential problem if a GP wants to dial in for one patient, but it does know who we think the GP is. So that might be wrong. It gets pulled from the hospital PAS, and as you would know and we would know, sometimes that's accurate and sometimes it's not. But mostly those patients have been referred more recently, so it's probably a bit more likely to be correct. Unfortunately, that system's perfectly capable of sending notifications out electronically, but we're hobbled by what I think really are short-sighted policy issues, but issues outside the local health district. They're issues in health IT. So one thing we can't do is automatically send a notification to a GP when one of their patients is listed for a meeting. Although, if there's interest in going down this track, I can certainly look at, producing a bit of paper potentially that, would need to be faxed or something like that. So to me, just kind of thinking through the problem, the first thing is letting you know when your patient's going to be listed at a meeting. And we could potentially semi-automate it the way we run our meeting. I'll come back to the other meeting shortly. With various degrees of difficulty, they would find it more difficult. So if there was going to be any trial, it would probably need to be in our MDT. I guess we could possibly have to think about it. As long as we've got an email for the GP, I would have to prevail upon our part-time clerical support, who supports all of the 7 MDTs, to see whether they could, if we've got if we're discussing 8 patients or 10 patients and we've got GPs for 7 of them, I could discuss, can we add the GP? We have to manually add the GP's email addresses, to the notification for the meeting. And I mean, if that happens, that notification goes out with the patient list and with a, currently it's a PEXA dial-in. That's what we use because it it seems to work best, but that is accessible from all over the place. We've got VMOs and radiologists dialing in from external to the health service. I mean, that's the sort of thing we would need to look at doing. If we did do that, then, you know, the GP would get an email, whatever email address we had, and I'd actually have to look at, just write a few things down while I'm talking, and I'll talk for a bit and then let you interrupt me and ask me questions. But as I'm thinking through it, I mean, whether we've got GP email addresses is another question. But if we had them and we sent that out, it would potentially be open to that GP. I mean, there's, you know, I would obviously talk to my colleagues and make sure they were happy, and I'm confident they wouldn't have any objection. It would potentially be open to that GP to dial into the meeting. Unfortunately, the GP would have to guesstimate when their patient would be up, but we really have no way around that. I mean, we finish one patient's discussion when it finishes and then move on to the next. But, you know, if the GP's there for an earlier patient, it wouldn't really matter. I think the next shortcoming is the meetings tend to be reasonably, the discussions are pretty brief. I mean, we've got a patient summary, which the hematologist puts in. We don't discuss too much about, unless it's some very unusual situation, you know, we won't go through chapter and verse about prognosis and outcome with the various protocols, because, you know, people know that by and large. Certainly we sometimes have quite long discussions about that when it's some unusual situation where the hematologist is scratching their head about what to do. And I mean, while there's stuff to discuss, we try and take as much time as we need, but there's certainly not long drawn out discussions. I mean, if we've got 12 or 14 patients, we will do our best to do them within that hour so people can get on and do whatever else they need to do. And it's mostly focused on, with some patients, obviously, particularly older patients, you know, should we treat them or should we not? You know, is it reasonable to palliate this person from day one? And, you know, obviously with younger patients, it'll be, are we aiming to transplant them or what's the plan? But it's pretty much focused on those sort of treatment decisions. So I've sort of ranted a bit about and highlighted about some of the problems we have, which can make, if we trial something, you can probably foresee how there could be some small glitches here and there. But I mean, that's probably something that if there was interest, we could trial. I don't know that, as I say, I'll have to check where I would find email addresses, because I think we have to email this thing out to you, or you haven't got the links in a convenient way that you can use them. Although, you know, it's possible to dial in on a phone. So that's how I'm thinking at the moment. I don't think it's impossible, but it's not that easy, and it wouldn't be as painless for the GP, you know, as you would potentially like, because obviously all the other folks coming to the meeting are coming for the whole meeting, so when they know when it starts, they just don't know when it finishes. So I mean, can you see any interest or value in trialing something like that?
Is it from my
the sort of
perspective?
thing
Yeah.
you could do.
I think it sounds like you've just got to jump in and give it a go, doesn't it? And just see whether there is an interest. If you do manage to get the 8 emails for those 8 GPs that own those patients, I guess, and no one turns up week to week, then it's a dud idea, I guess. But is it useful for GPs to be involved in those sorts of decisions? We, I guess, bring a different lens to those discussions, but we wouldn't want to come in expecting to talk for 15 minutes about our own patient when you've got 12 to get through in an hour. So it might be 3 minutes, and that. We don't want to make you run late.
Oh, look, you know, I mean, obviously it's it could be relevant, obviously. I mean, you know, if it's a patient well known to the GP, you'd know more about their social family situation, about their level of function. We will have, with the older patients, you know, there are things we will have tried to suss out to the level we need to, which, you know, probably isn't super fine-grained, but certainly with some of the older patients that, you know, I'm sure it would be helpful. So, and, you know, I guess we've got younger patients with who we think may have, you know, social support or psychological issues with coping with the sort of treatment we're thinking about. So, I mean, I think there are lots of aspects that a GP could contribute to. Then again, we're not talking about really detailed nitty-gritty planning. It's pretty much, you know, the go no-go decision and what we're going to do, and then, you know, there's obviously more discussion after that. But I mean, I'm sure it could be useful, and it would be useful if the GP was, you know, clear what was going on with the patient as well. That would obviously be very useful.
Yeah, that's where it stems from, isn't it? Yeah, that information coming back to us. So if that just means that it's a summary of what was decided in the meeting that is sent to us in a timely fashion, that might be all that we need, and a way for us to feed back to you.
Well, that happens I mean, from our meeting, you know, we generate a summary, which is pretty terse, but we generate a summary on every patient out of Mosaic, and that summary gets sent to the GP. So that's been happening for 2 years. So whether they ever get there or whether anyone ever sees them, we've never had any feedback on them. They're pretty brief, and that's because all the information's manually put in by us, and probably because I can't type well enough, I can't touch type well enough, and I've structured the system around that. You know, other younger members of the department can touch type a lot better. So maybe the summaries will get longer with time. But we do that already. And in terms of getting GPs' email addresses, we have no resource on the you know, 2 days before to say, oh, we need these GPs' email addresses. I mean, I would get lynched if I volunteered our coordinators to do that.
No, I think that's a wider hospital issue as well. Like it's a question for the wider hospital and PHN as well, whether PHN can help with that. If the hospital doesn't have GP practice emails, how do we make that available? Because that's important to all departments, I imagine.
Yeah, exactly. And I mean,
sorry, Cambell. I was just going to say, to run a little test, could Ellie perhaps we just start with a small group that put their hands up that, Ellie, you go out and say, is anyone interested in this? And then we can quite easily collect that known group, and then you need to recognise the patient related to those, Cambell.
I was thinking if we were going to do this, I would have thought we would send out an expression of interest thing and with a very brief explanation of what people could expect. And if anyone was interested, they could email back and we would put them on a list whether we can stick them in Mosaic, so that actually we probably can't. I would be asking whether we could stick them in the PAS or somewhere if they agreed to that. If they didn't, we'd just stick them in a list on a PC somewhere, and try and find a way of see if we could sort out a sensible way of just dealing with them. I mean, the best thing for us to do if we did get GPs' emails would be to also get permission to stick them in the PAS if we could, so that that's a source of truth, because that's where our system pulls all the GP demographics from, and patient demographics, and then our system would know if there was a GP email address, and we could print it out on something, and it would then be sort of workable for our admin support to actually do this, and it would potentially be translatable to another MDT potentially, but I mean none of the others.
Yeah, Taya's just asking if anyone has seen your MDT summaries at the other GPs in the group. She hasn't seen one, but the other GPs, have you seen an MDT summary? I think I had one come in last year, but just one.
Yeah, I don't think.
No.
I mean, I suppose heme diagnoses are, well, they're not that uncommon, not super common, not that uncommon, but yeah, that was going to be one of my questions for the meeting. Has anyone seen one? And are they useful or are they not? But
they would be useful if we got them, I guess. Can we do an audit of that somehow, just to make sure people are receiving them? That would be important to know, wouldn't it?
Potentially, but it's it's auditing an indefensible 20th century system, which, you know, I've brought it up regularly for a decade or so, or more really, but certainly, you know, in recent times, it frustrates the hell out of me that our discharge summaries get emailed out. I don't know whether they arrive at you guys either, but they come out through the electronic drain pipe that goes from us out to health and then out to the world, and our documents go through that same pipe, but we're not able to route them in the same way for reasons that eHealth can't really clearly explain, except that it's not a priority for them.
So do you know how they arrive? Is it in My Health Record?
I really don't know. I'd have to ask these guys. I'm told discharge summaries go out electronically through that pipe, but I don't know how they end up at the GP practices.
They're into My Health Record, and we have lots and lots of problems. We have a lot go out, but then getting access is a bigger problem, and we all know it's a very difficult and frustrating thing to solve that we're trying to work on. But Myron might just follow up on the route of arrival for those reports. I think we might go back to Kirsty Toms while Kara's away and just see if she knows where the mosaic reports go.
Absolutely, Fiona, and I was going to propose the 21st century solution, Cambell, for you. And this is voice-activated summary taking. How is that? All the slow typers.
Given that we're only talking to ourselves, apparently, it doesn't really matter. But I mean, Liverpool and Wollongong did run a project for some time doing exactly this out to GPs, and look, I gather there were some warts with it actually being able to track arrival and get a message back confirming arrival, but quite a lot of work's been done on it, and it's just interesting that it's regarded as such low priority, this sort of communication out to general practice in a way that will actually get into your systems.
Yeah, that might be. Messages are getting through to us, and we'd be happy with just that timely communication. It might avoid the need to jump into the MDT.
The messages are being sent in exactly the way as letters come from our department. You know, they're basically printed out by the same people because they've got to do that, and which is just shocking, and either faxed or mailed or whatever, you know, whatever mode of reception we've got. So anyway, that's just an admission of, you know, horror. Yeah. If there was, I'm more than happy to. What could we do? Well, look, you just have to send us some patients that we're interested in discussing, and but look, I guess we can try. We can. We'll do that. We'll at least. I'll talk to the troops about, because we've got no way of actually auditing whether these things have been printed. We can't do that. We can't do it with our letters either, which is a problem. But, you know, we just try and have systems to deal with it.
Would it be possible to pull a current list of patients and who their GP is, and then just check whether they're receiving?
Yeah, I'll talk to our long-suffering secretaries
Oh.
And, we'll just. We had an MDT today, so I'll
Just use that as a
yeah,
snapshot. That'd be good. Yeah. And the email.
We'll just see if they arrived.
The email issue is a larger issue. We should follow up as well. Fiona, can we add that to our list to action as a group, just to make sure that's happening somehow?
Can do. I'm just emailing ICT and health records as we speak. Cambell, what's the name of that report? Mosaic. The Mosaic report.
It's it's an MDT summary, but
Okay.
I mean, it doesn't get sent it gets sent to PowerChart, so it gets sent to the EMR.
Okay.
So it traverses the pipe, and those electronic routing machines that it goes through can potentially, the LHD could send it out, but there's nowhere to send it to that will get to where it needs to go. That's the problem. So I don't think there's any difficulty the LHD sending it out into the ether. It just can't actually be addressed in a useful way so that it gets out to one of the one of the mobs outside that can actually then route it on to the GPs.
Yeah, I really wonder if this gets kind of sent to the My Health record. It would be really interesting to see. I'll speak to Kirsty, Fiona. What do you think? I think that's a good start. It doesn't? Cambell?
Well, you're welcome to tell me that it does when you have a look, but I put a fair bit of money on the fact that it doesn't.
It doesn't, okay.
It stays internal to the LHD apart from the ones we print out and try and, poke out the door.
And then my question, should it be actually sent to My Health record? Is this the best place to actually send those?
If we were going to send it there, I would check. I don't want to offend my colleagues, but again, I'm sure they'd have no problem with that. I think, or the only problem with sending something like this there is, if all the subsequent correspondence relevant stuff doesn't go there, I mean, plans change and they can change within a week or two. I mean, it really has relevance. It's a document that really has relevance at the time, and, the GP or, the emergency department or someone, if the patient comes into ED, are really the people who are worth informing. And once it's 2 months down the track, it's not the right document. There should be other correspondence, which is more informative about what's happened and, where the patient's at. So if stuff was going to My Health record, it'd be a good discussion to have. But in actual fact, I'm not sure this would really be the right thing to go there, unless that was actually an effective way of. Well, I mean, if the GP doesn't know it's there, they can't look at it. So.
Yeah.
I think it would be better to go through secure messaging to the GP, because then don't you as GPs get a notification that you've got a new piece of mail, a secure messaging new mail?
Yeah.
Yeah.
So that would be better.
From our side of the fence, exactly that has been discussed ad nauseum, really, and it's something that. Well, from my perspective, it'd be, I mean, general practice, you guys may have been discussing it ad nauseum as well, but I mean, the more it gets raised with health services as a really important, patient safety, patient care initiative, and probably be raising it from outside is more likely to get attention than raising it from inside.
Yeah, thank you, Cambell. Just in the interest of time, I guess we just better make sure that other GPs are happy. Did you guys want to ask any questions or comment while Cambell is here, just on either the idea of GPs being involved in heme oncology, MDTs, or what we've been talking about with secure messaging as the summary? Amita?
Look, I can assure you that I think we do get discharge summaries. I don't know about your notes from the MDTs. I would have to look at a couple of patients, but we certainly get discharge summaries. They appear to, they seem to come from the hospitals far better than they used to in the days of paper envelopes coming with the patient. So that's something that's reassuring. I frankly have my doubts from what you're describing that a GP is going to, in the middle of their busy day, be able to find that time for a 3-minute consult, like contribution in the MDT meeting, to be able to say, yeah, I've got something of value to contribute, that I'm going to be on hold or whatever for all that time. So I'm not sure that there's a lot of value in that, frankly.
Yeah, I'm not suggesting it because I think it's useful. I'm just trying to paint how the meetings run.
It could be useful, but practically, the practicality of when you're consulting and how the meeting is run, it sounds like it might be really difficult.
Yeah, I mean, it's that's been our view really as well.
Yeah, and something as simple as a phone call from one of the RMOs after the MDT might be all we need as well. Just a quick chat or a question, if and that's a schmozzle at the moment for you guys as well, isn't it?
Well, they're not always at the MDTs. They're usually pretty busy on the ward. They don't have time to attend at that time. Usually, some of the MDTs happen after hours. I really don't. I don't think that's going to happen. I mean, if we could put in a system, then that would work. I think that can happen. I think making sure these notifications get to you would be a plus. I guess the next thing I would raise about that is that most of the MDTs really don't have a system that can notify you after the MDT. So if our system's not working, well, we obviously need to fix it so that it is working the way we expect. It would be great to get some feedback as to how useful that is one way or another. If it was regarded as useful, then that gives me something to take back to the other MDTs and apply some pressure as to all the reasons why they need to lift their game. And they could, it's probably more difficult for some of them. We're familiar with using Mosaic, so we can use it, but it is built so the other MDTs could use the same functionality. One of the MDTs, probably the next, well, really one of our very functional MDTs, a number of the members were interested in using this system because it can produce immediate documentation of the decision at the meeting. And interestingly, one of their members was very unhappy about having the opinion of the meeting actually recorded and put into the EMR and sent out to the GP, and he felt this was a big problem. So, there are challenges, but and a couple of the surgical MDTs are really, they document things, on. I think they do actually document the outcomes, but they're documented in a way that is not visible to anybody except them, and that's more of a challenge. But I think if we know that. If we know that there's significant value seen in something happening, some change, it does make it a little bit easier to push the issue a bit.
Agreed. Con, did you have any other thoughts before Cambell goes?
No, that's all understood. Yeah, probably may just try this, sending of the summary of the MDT, see how that goes. Of course, we haven't received them so far, so if we can send them out, we can, feedback on that.
Well, anyway, as I say, I'll do the 1 week audit. Yeah. I might find something out that surprises me. And look, I'll send some de-identified summaries to Ellie, and she can you can give us some feedback. As I say, they're very brief, but
yeah, that would be really good actually, Cambell. That'd be great. Yeah. Thank you so much. Was there anything else? I think we can call it a night. Thanks for joining us. If everyone else is happy.
Thank you.
Yeah. Thanks everyone.
Well, thank you.
Thanks so much, Cambell.
See ya.
Yeah, lots of challenges.
I think, yeah, just in the...
Okay, thank you.
Looks good.
So really, as I said before, I wanted to just mention and talk about sort of the changes to palliative care over the last few years. I think it started in 2015, the area did a palliative care review, which wasn't just looking at the palliative care service, but the end-of-life care across the whole of the LHD. And out of that review, a very long report was written, which had a lot of recommendations. And so this overview is going to talk about sort of some of the enhancements to the service, the recommendations, and what really sort of current state of play as well. So I'll just run through sort of the slides and let you know what we've been doing. As some of you may or may not know, the palliative care service has multiple branches to it. We feel like we're growing quite rapidly. We have a community arm, which is mostly involved with your team here. And we have community palliative care nurses that are aligned to the community nursing sectors. We have palliative aged care support service, which works in the RACF sector. And then we also have bereavement counselling as well. We have a Gosford Consult palliative care team, a Wyong Consult team, and most recently in the last year we have opened a palliative care inpatient unit at Gosford Hospital as well, which I'll talk more about later. So just wanted to give you an overview of the arms of the service that we have. So as I said before, the palliative care review came up with 144 recommendations. One of those was appointment of the Director of Service, and I was lucky enough to be put in that role. I've been in the role since August 2018. We've had a change in the service manager. Sally Meacham is our new permanent service manager. And a steering committee was commenced to try and oversee the implementation of the very sort of broad recommendations that came out of the review, and that has some input from the PHN, the Advanced Care Planning and End of Life Care Committee that sits within the LHD, and also some of the recommendations just sat within our service itself as well. Well, I'd like and be pleased to say that most of the recommendations are actually now business as usual, and so we're looking to actually wind up the steering committee because what was all wanted to be implemented has mostly been done, and we feel that we don't really need to meet sort of in an ongoing fashion from that perspective. What we've been doing has been very gratefully enhanced by a huge input of funding into palliative care from New South Wales Health, and they've put in over 100 million across the state in the last sort of 5 years or so, with more coming. And the sort of things that we've been able to get at CCLHD are pretty broad. So we had funding for a new palliative care staff specialist. We had funding for a CNC to support end-of-life care within CCLHD hospitals. We've received funding for 8 palliative care nurse positions over 4 years, and our final 3 positions are due to be appointed and commence from July this year. So that's been very exciting. They've funded an Aboriginal health worker in palliative care, which was initially 0.5 FTE and is now full-time. We've received ongoing flexible funding to enable us to have initiatives within RACF to increase support there, and also to try and help keep residents of RACFs in place. We've had some project support from the government to plan for our new ward and introducing of our palliative care outcomes collaboration data collection, which I'll talk a bit more about soon. We've had federal funding also to help with RACF supports until 2024. We've had enhanced allied health funding. We've got a social worker, which for some strange reason we didn't have until the last few years, but that's great because it's a great need in social work in our patient population. We've had further funding for allied health, so we now have 2 palliative occupational therapy staff. We've had bereavement services enhancements, which are just being recruited to at the moment. We've had educational funding enhancements. We got $400,000 for minor capital works, and that was used to upgrade and renovate the old maternity ward at Gosford Hospital, which has become our inpatient unit, which opened in April last year. We also were fortunate enough to get $330,000 towards palliative care research within the LHD from the Joint Regional Health Partners Research and MRFF grants. Oh, it's exhausting just reading this. It's great. Just heard this month that we are getting a further $350,000 a year for specialist palliative care, which we're hoping to use towards medical enhancements. There is some funding coming for enhancing community care in MDT clinics, so that's sort of being expressions of interest sought for those at the moment. And on top of all of that, there have been some end-of-life care packages funded by the government, not provided by us, but to support patients at home. Those packages were initially provided by Hammond Care, but are now actually being switched to ADSI as a care provider. So that's sort of the list of enhancements that have enabled us to, I think, actually make a big chunk of those recommendations happen. So with all those enhancements, obviously, what have we done for the palliative care service? we now are able to run a 24/7 medical on-call service. So our nurses are actually on call 7 days a week, 12 hours a day from 8:30 a.m. in the morning to 8:30 at night. But we didn't previously have a medical service that was able to run 24/7. So we are actually available to give advice after hours, and of course in normal working hours as well, to anybody that wants it, health professional wise, to the hospitals, the ward and community as required. We have provided extra CNS2 nursing support to our Gosford Hospital consultation team. So we now have a 7-day-a-week hospital consult team there at Gosford Hospital. We've implemented a community triage system, so all our new referrals, our response is matched to the need. So patients get triaged with assessment tools, a very comprehensive telephone conversation with either the patient or their carer, which helps us try and determine who we go and see most urgently when we have that first referral come through to us in the community. We've got 2 palliative care liaison nurses dedicated to support the RACFs. We have one based north, one based south. And they look after all the patients in the RACFs that are referred to palliative care and provide support to those staff working in those units as well. We have a palliative care CNC that's been driving a lot of the hospital-wide changes for improvements in end-of-life care. As I said, we've opened our ward. And we've also joined something called the Palliative Care Outcome Collaboration, which is really a data collection outcome measures for patients, which helps us to have improvements, drive improvements, but also to benchmark against other services as well. So we were quite late to the party on that. It's a nationwide collaborative and also used in Ireland and other countries. But we've just joined that when our ward opened last year in the inpatient environment. We're hoping to join it in the community environment soon. As I said before, we had those allied health enhancements as well, so lots of changes have happened to our service. Just a little bit more about Peacock, as we call it. Peacock is this palliative care outcomes collaboration. It's a national program and it uses clinical assessment tools to try and determine a patient's disease trajectory, and the idea is that we can see how well we're doing, we can compare ourselves to other services, and we can actually use it to determine how often we need to review patients. So there's multiple tools that we look at, often about functional performance of patients. So we use a Karnofsky modified Karnofsky scale. We use palliative care phases such as this here. So we talk about our patients being stable, so their symptoms are controlled, unstable where they have an urgent change in treatment required to help with a new problem. We have deteriorating patients that are sort of expected and gradual deterioration. Then we have terminal patients as well. So this is one of the part of the language that we use in that when we're describing our patients as they change through their disease trajectory. A little bit about our research projects. We have 3 projects on the go at the moment. The funding that we received from the Regional Health Partnership initially sort of had some workshops with people throughout the LHD that were keen to have and had an interest in palliative care and palliative care research, and we ended up settling on 3 projects. So the first project is a rapid review looking at the literature around models of care for end-of-life and dementia. I'm co-chief investigator with Danielle Davis, one of our older persons OTs, who works in the BASIS team. We're looking at improving the end-of-life care journey for people with dementia and their carers. And then my colleague Tom Osborne is looking at improving what happens in emergency care towards ends of life. We know a lot of our patients do end up in emergency in the last few months of their life, and Tom's sort of exploring what's happening there. So these projects have been through ethics, and we're actually just starting collecting the data on those now, and we hope to have some reports out nearer the end of this year. So that's all moving ahead, thankfully with the help of research assistants, without which I don't think we'd have so much done. But that's very exciting. We've never really had the chance or the capacity to be involved in such research before, so the funding has made that very much appreciated. And these projects are local projects, so hoping to improve models of care and improve journeys for patients locally, because obviously that's the most important thing for us. Other things that have been initiated, and these may seem minor things, but they're very big things for patients and their families. All the wards now provide uniform bereavement information. When we looked at the wards, people would have a mishmash of different pieces of paper. It's all been collated into nice one booklet. Bereavement bags are now given to relatives for their belongings. It used to be that someone had died and the relative would come pick up their belongings. They'd be given like a black plastic bag, which is very undignified, to take their belongings home in. They now have a very nice handmade and sewn canvas bag that's taken home with their belongings inside, that is actually made by the auxiliary for us, and also other community groups have come on board and helped with those as well. The LHD was a pilot site for electronic advanced care planning and resuscitation plans on EMR, and that's now all going live and all working well. We've also been an implementation for the end-of-life solution on EMR, which is our electronic medical record and electronic palliative care consult, and all the Peacock tools that we use can all be seen visually on there and put in there to help us track our patients and their trajectory. Things like online memorial services have happened as a collaborative between the volunteer services, palliative care services, the spiritual care teams. So those things have been happening in COVID, and they've been area-wide rather than just palliative care services, and they're available to view at any time on the intranet. And we've also sort of looked at documentation. So this has been very much driven by the Advanced Care Planning Committee, looking at providing leaflets give to relatives about when someone's died in hospital, what to expect when someone is dying, and similar sort of information for what to happen at home as well. So that's all come about in the last few years. I just wanted to just let you know a little bit about what's happening in our service. As we've had quite a sort of sharp increase in referrals over the years. We had a bit of a sort of stagnation 2013 to 2017, but in the last financial year our referrals had quite a large jump, and it looks like that's continuing at this point in time. Similarly, our inpatient consult team activity is also rising rapidly. I think we've certainly got more of a presence at Wyong, and that's making a big difference. It used to be sort of 70-30 split with the Gosford team having more of the work, but it's much more 60-40 sort of split now, and Wyong's getting a lot busier from that perspective. I just did a little snapshot of what was happening on the team yesterday. We've actually, I think this may be a record, we've had 57 new referrals to our team in the last 7 days. In Wyong, as of yesterday, we were supporting 12 patients with the consult team, 24 patients we were supporting in the Gosford consult team. We had 9 inpatients on the ward and 291 registered patients in the community. And of those patients, obviously about half of those were stable when we look at their phase. There are only a couple in the terminal phase, but quite a few were actually deteriorating, and obviously with those patients we're planning for end-of-life care, and unstable patients with new or emerging symptoms that we need to get on top of quickly. And obviously we do still follow up patients and their families, or their families after patients have died. Our nurses will go out and do a bereavement visit to collect equipment and just check everything's okay after death. So that's just sort of what we do on a weekly basis. I hope I'm not taking up too much time, but I just wanted to mention the ward. The ward opened in April last year. We've cared for between April and November, the last time I sort of crunched the numbers, we'd cared for 189 patients. We'd had 157 deaths on the ward, and our average length of stay was 11.5 days. Within that, we had some very long stays of mainly younger patients that really had nowhere else to go, whose care needs couldn't be met in RACFs. We had some direct admissions from home, which was always our intention to try and bypass ED as much as we could. And we had taken some transfers from Wyong and Woy Woy and a couple from Sydney hospitals as well. Just a couple of pictures of the ward. Obviously the rooms have been made to try and feel less like hospital rooms as much as that is possible. That's the picture on the left of a single room. We have 8 single rooms on the ward and 2 two-bedded rooms. So although we are funded to 10 beds, we often do go to 12. This is the visitors room in the middle here, and they have a kitchen for visitors as well to be able to make themselves tea, coffee and get ice for their relatives. And we have a beautiful outdoor deck which has furniture on it now, so this was just at the opening of the ward before the furniture arrived, and it's a great space for people to be wheeled outside, spend time with families outside, and we actually had a patient die out on the deck at his request and family's request, which was actually went really well. Okay. I feel like I've given you a whistle-stop tour, but I think we have quite a few challenges at the moment for the service, notwithstanding the COVID challenges of meaning that no one seems to want to go to hospital, so everyone seems to have lots of referrals in the community currently. We seem to get obviously increasing referrals, but increasing complexity of some of those referrals, especially the patients that may be having prolonged treatment for their cancers, and it seems to be coming with that difficult symptomatology, which can be very hard to treat, despite sort of lots of attempts with us and using the acute pain service as well to help with interventional management. So we have some very complex patients out there on very complex medication regimes. Our challenge is, how do we spread the workload? Most of our staff work Monday to Friday. How do we try and cope with a 7-day-a-week demand? We're looking to increase our nursing capacity, so we have 2 nurses on call at the weekend to try and make that more manageable. Obviously, our activities going up at Wyong Hospital. Do we actually then have a nurse available at Wyong Hospital at the weekends? That's a future thought for us. How do we decide where to best place? Oh, lost it. Sorry about that. Have you lost the presentation?
Yeah, it's okay. I guess we were almost at the end, weren't we? So
yeah, we're almost done. Except I've lost my train of thought now.
Yeah.
How do we decide where best to put our future nurses, and how do we maintain a flexible workforce that can work across all the sectors? I suppose is another issue. We have challenges with medical staffing. We are 1.4 FTE down in our medical staff specialists at the moment, and last lot of recruitment was not successful, so that's a problem for us. We've got some priorities to review our bereavement service. We'd like to implement our outcome collaborative information peacock in the community. We'd like to make sure that we can translate our research findings into meaningful improvement in patient care. And there's also obviously a possible expansion of our inpatient ward to 14 beds, depending on funding and activity, that we have the capability to increase the numbers if need be. So lots of things happening sort of in the palliative care space. I'd be really interested to hear your thoughts on things, and also we've actually had Dr. Catherine Palmquist working with us in the last few months in a sort of a GP sort of VMO capacity, and we've been sort of brainstorming things together about how we can sort of help improve GP collaboration with the service, because I know there's lots of people interested in palliative care out there, but I don't have easy answers, so I'd be interested to hear your thoughts.
Thank you so much, Sally. That's incredible. Oh, it's not often, is it, that you get just thrown bucket loads of money?
Oh, it's great. I feel a bit guilty sometimes. Everyone says, "Oh, I haven't got any money." Okay, we've got a fair bit, but it was needed. I think there had been very little money for a long time, so it was very much needed.
Yeah, sure was. Yeah. Maybe you can stop sharing your screen so we can see each other again.
Oh, sorry.
And have a bit of a chat. Firstly, I guess if you don't mind, it would be really great to be able to share your presentation with some other GPs. We do have, I forgot to mention in the beginning, we've recorded the meeting tonight, but your beautiful summary of all the successes, I think there'd be some other GPs interested in seeing it, so we can put it up on our GP Association Facebook page if you're willing.
Yeah, that's fine. Who do I send that to you, Ellie, or
We'll do that from our end if you're happy for just our snapshot of you speaking and your slides to be shared. Yeah. Is that something we can do, Maya, Fiona?
Yep. Ellie, absolutely. We normally just cut out the presentations out of the recorded meetings, and we could organise that and share, so that can be organised easily, Ellie.
We could always share it on the PHN platform as well, which is quite a good platform to share things on.
Yep, yeah, that's a good point.
Joanne Coote is asking, can we add to the PHN Educational Library too?
Yeah, absolutely.
Yep.
Thank you, Sally.
No problem.
I have one thought, but I wanted to just let others speak. Perhaps the GPs have got other things on their mind you'd like to ask Sally. We've got 7 minutes before the next presentation. Has anyone got a burning question or suggestion there?
Ellie, if no one else, sorry, does anyone else have a question? Because I do. This is Maya.
I do mine, but you can go first.
Sorry, I was actually just going to say, and what really caught my attention was the sheer number of people that actually, you recorded 157 deaths. And, as an ex-nurse, I am just wondering, what kinds of support do you have for staff that kind of, are dealing with palliative care patients? And I know that, no training can prepare you for it. How do you manage, supporting your staff? And is there anything kind of that you do, to help them out through, I suppose, witnessing, so much death and pain, I suppose?
That's a good question, Maya. The main thing that's happening on the ward is they're having sort of periods of reflection, so sort of sessions where they can actually sort of talk about the patients and reflect back. So that's been happening on the ward and also happening with our community palliative care nurses as well. So almost like sort of guided supervision. And then with regards to our bereavement counsellors, they have supervision. Of course, social work staff sort of have supervision built into their into their work. We don't have anything formal for medical staff. We tend to use peer support and our WhatsApp group for our sort of supervision, and a very sick sense of humour, sadly.
You need that.
I think you do, yeah.
Thank you, Sally.
Taya, you had a question?
Yeah, hi Sally, how are you going?
Hi Taya.
Thank you for coming along and sharing that. It's really good to see what's happened and what's been achieved. It's really great. And I'm just reflecting on, why do you think there's been such a big jump in consults? Do you think people are now understanding about palliative care a bit more and more willing to refer, or has it got anything to do with COVID? Why such a big...
I'm not sure. I think COVID might be having some play to it, because some of the patients we'll go to in the home absolutely refuse to go to hospital, and for the reason, obviously, if they go to hospital, they're often not going to get very many visitors, or the visitors are going to be limited. So I think that does shift things to the community. I think we're seeing a lot, maybe it's PR, but we're seeing a lot of more frail aged sort of patients being referred as well. So I think traditionally palliative care was seen very much as just cancer patients, but obviously it's not about your diagnosis, it's about your needs. And I think that message hopefully is coming across loud and clear, that we're happy to see patients regardless of diagnosis. I think it's probably a combination of things. And I think some patients, certainly the malignant patients, are living longer with new treatments, but often more consequences of those treatments and more side effects. And maybe our growing population.
Or is our population aging more?
Yes, I think it's a bit of everything.
Thank you.
I wondered, Sally, actually, as you were presenting those numbers, whether it had to do with your increased capacity to accept referrals. There was a long time where you weren't able to take on referrals due to lack of workforce, but perhaps your referral criteria haven't changed.
They haven't really changed. I don't know that we ever used to refuse referrals. I wonder if we were probably not welcoming them so much. Maybe that's the difference. I'm not sure they ever got refused. We try and, we look at all the referrals and they get triaged. And even if we think that's probably not somebody that's going to have ongoing relationship with our service, we will endeavour to do an initial assessment and then try and sort of point them in the right direction. It's very, very rare nowadays that we will actually look at a referral and say that's not for us. So I think that happens very rarely. Yeah,
it's certainly been our experience recently, for sure. Con, it sounds like you've got a comment there.
I was just going to ask Sally, with the 24/7 you're talking about, is that part of the community as well, or?
So that's for medics. So yeah, community from a patient's perspective, Con. Community. If a family member or patient rings up, they will get through to one of our nurses up until 8:30 at night. After 8:30 at night, they actually get directed via Gosford Hospital switchboard to the after-hours palliative care statewide helpline, which is a telephone support service. But medically, staff-wise, if as a GP you wanted some advice, we are available 24/7 medically through the Gosford Hospital switchboard. So very happy to give advice after hours. As long as it's not 2 in the morning, no, of course, but whenever it's needed. Hopefully you're not giving advice at 2 in the morning either.
No, that's right.
But very happy to do so. And I think people don't realise, if you're not sure, you're not sure, do I refer? I'm not sure about this patient. What do I do? You can just give us a ring, you know, Monday to Friday as well, normal working hours through the palliative care office. We're happy to take calls and try and advise the best we can if you think that will save you some issues or save a referral or, you know, just help tide things over. We're very happy to have a conversation. And please feel free to pick up the phone. If we can't talk at that time, we'll get back to you as soon as we can.
It's lovely to know, Sally. It's always good for us to get those reminders. And we might, with that video of your talk tonight, we might just send a little prompt to the other GPs to say you're happy to get those calls too.
Yes, absolutely. Yeah.
I had one thought just as you were talking about electronic advanced care directives, and I know that we do a lot of discussions about those in general practice. So I did 3 of them today, but I wonder how many transfer to you guys and all the work that we do. Is it just repeated in LHD setting, and how can we better get that to cross over?
Sorry, I'm just I warned security I was here late, but they're just sort of doing the rounds, so I'm just checking that they're not going to knock on into
lock you in.
Yes. The advanced care planning, what we do in the EMR is we actually ask patients if they have a plan, and then we can scan their plan in that they bring in. So it's a plan that you make that then gets uploaded. So we look to see if we have it, but then it also gets made. If one's made in the community here, we'll actually send it straight to, and it gets uploaded very quickly. In the hospital, I believe it gets uploaded when they leave hospital, and all their notes get uploaded on leaving.
So it's definitely useful for us to be doing those. Yeah.
The patient just needs to remember to bring them, I think, and show them to people when they come into hospital, which is not always remembered. But we will certainly log if they've got one, and we can log that on our EMR system if they actually have one.
Oh, very good. Does anyone else have any last minute thoughts, comments?
Ellie, can you hear me?
Yeah. Yeah, hi, Amita.
Right. Hi. I think my audio was not right. Sally, thank you for that. It's fantastic. And I've had to use your service lots, including for my parents. I just had a question about, the 24-hour availability. So I've run into a problem where the service wasn't available for weekend admissions. So these will be people, say, Friday night, they turn up in the ED, they want to go home, and we weren't able to access palliative care at all to set them up over the weekend. So is that changed now? It would be possible to do that?
I guess it depends what they need, Amita, at the weekend. So we only have one nurse at the moment on call at the weekend. With backup from medical. So if they're in ED and they need syringe drivers and things, it sometimes can be quite hard for ED to set that up and get that going. So that is a little bit limited. If they're known to us, it's often a bit easier. If they're already known to us and then we have orders in place, we can often go out and do that the weekend. But if they're brand new patients, that can be quite tricky, because I think a lot of people in ED underestimate what you actually need to put in place to manage that at home.
Well, yeah, because we couldn't do it over the weekend, essentially. We were told, no, Palliative don't accept admissions over the weekend, like new patients. And like you said, because the whole thing's got to get set up and,
we actually haven't been doing new referrals at the weekends. We hope that when we have two nurses at the weekends, we might be able to have capacity to see new patients at the weekend, but as you see, geographically, it's really hard for one nurse to be covering the whole of the Central Coast.
Slightly.
It makes it very difficult. So, yeah, we do tend to be very much, unfortunately, a 5-day-a-week service in the community mostly. So new referrals are seen Monday to Friday. We have seen the odd urgent one at the weekend, normally on pre-arranged, and if it's comes through Friday afternoon and we need to think they need to be seen Saturday morning, we can sometimes do that. But that's more of an exception rather than the rule at the moment. But it'd be nice to have a 7-day-a-week capacity, wouldn't it?
But at least we can ring now and get advice, on the weekend.
Absolutely. So if you have somebody at the weekend you need advice for, occasionally I'm giving advice to the nurses that are going out in the outreach team to the nursing homes as well. So we're not necessarily seeing patients, but our nursing homes have gone out, staff have gone out to see them. I forget their acronym for their team, but we've given advice about end-of-life care medications and drug charts when they haven't been able to get GPs to try and keep people in nursing homes in that situation as well. So we do what we can, but it's not always perfect, I'm afraid.
So good, Sally, to hear you talk tonight. You've got to get home still at hospital there, so let you get out before.
You can tell from this lovely mood lighting, can't you?
Oh, very good. No, it's fantastic.
Thank you for having us.
nice for us to hear that Catherine Palmquist is on the case as well. So just keep chatting to her and come back to us if you need help implementing any of her ideas. And
yes,
great.
And unfortunately, our GP scholarship people have not been able to come in the last few months because of COVID. We think we have a couple of lined up due to come, and we've had a few GP scholarship recipients. Taya was one a few years ago, but we've had sort of 4 or 5 in the last couple of years. So hopefully once COVID settles a bit, we can have them back again and start those up again.
Yeah, fantastic. Well, thanks, Sally.
Thank you. Good night, everyone.